Good afternoon. Welcome to Dr Steevens Hospital, to the HSE media briefing. Could I ask the speakers first to introduce themselves from the left?
Damien McCallion, HSE National Lead for Vaccinations and Testing.
Colin Henry, Chief Clinical Officer, HSE.
Anne O'Connor, Chief Operations Officer.
Paul Reid, CEO.
And I'm Mark Brennock, National Director of Communications, and welcome to Lisa and Margaret, our Irish Sign Language interpreters. This briefing is being broadcast live on the RT News channel and on the HSE Live Twitter feed. And first, could I ask Paul to give an update?
Thank you, Mark, and good afternoon, everybody. We've been here many times over the past 18 and 20 months talking about the situation in our hospitals and generally related to COVID-19. And there's an obvious risk that the more we continue to talk about it and come back to talk about it, it begins to become normalised. So I do want to stress that today there's nothing normal in the situation that we're in. Nothing normal when we end up at different phases having almost a third of our ICU beds taken up with COVID patients, and indeed, as of today, as of this afternoon, just 90 COVID patients in ICU, and 458 COVID positive patients in hospital. Because it's not normal, as in normal times, they are beds that we would want to be utilising for people in terms of prioritised elective care. So there is always a risk that we lose sight of what is normal. So as I mentioned today, 458 and just before about lunchtime, 90 people in ICU. Important also to mention that what we don't always see in those figures are a significant number of those people in hospital. Right now, probably about 250 who are receiving advanced respiratory support. So respiratory support outside of an ICU. Many of those were, quite sick, and indeed some of those unfortunately will enter into ICU. So there's a high level of sickness from the patients that we are treating in hospital. It's equally important that we don't just look at the numbers today relative to what we had in our hospitals in January, because in January, everybody familiar in those dark days, we had 2,020 people in hospital and over 200 people in ICU. But there's a very different contrast between now and January. Certainly in January, from a healthcare perspective, we had ceased all non-COVID care and we're just treating urgent care and COVID patients. But equally in society, the whole society was under lockdown. There was not very much travel going on. We were treating a minimal level of trauma through accidents that would happen by travel arrangements, etc. There was no sporting activity. People were confined in terms of their activity. So it's a very different situation today by comparison with what we were dealing with in January. So while numbers are lower relative, the whole situation is different from a health system and indeed society. And thankfully, society and the economy and business and enterprise are fully open today, but just a very different situation. So I just draw the caution in terms of comparators between numbers in January. And the question we're often asked, quite understandably, is are we managing or are we coping? Are the hospitals coping? And you will have heard many of our hospital group CEOs and consultants out and saying they are managing to a level. But it is managing to a level, and we have to be careful in terms of what we interpret as coping. Because we are coping with, we're meeting the urgent demands and needs that come at us. We're meeting the COVID demands that come at us, but we're not meeting the demands that we want to get to and a real ambition to get to, which is a lot of our elective care and very long and impactful waiting lists for people for care. So when we do say we're managing to deliver that urgent care and meet the COVID requirements, but we're not getting to some of the other services that we really want to get to. And we do have an action plan, and we set it out a few weeks ago to get us to the year end to aim to at least cease the rise in the waiting lists, and we are actively working on that. Many of our hospitals are still getting to much of their waiting lists, and many are not getting to the others at all. But that is something that we want to keep focused on in as many hospitals as we possibly can. So just in relation to the virus, therefore, daily increasing levels of transmission of COVID in the community is causing significant and unrelenting pressure on the health system overall. and many aspects of it under particular duress. We are at a level of transmission in the community that has forced many aspects of our response of our healthcare system overall into surge responses, where we are dealing with a very disproportionate set of demands across the board, whether that's in our GPs and our general practice and demands that they are under, our testing and tracing system overall, our public health teams responding, our hospitals and our ICU, and indeed right now our compliance checks through our environmental health officers checking for compliance at industry level in terms of the COVID compliance levels. And we're also doing this with 3,500 staff right now, and probably rising out through sickness with COVID or as symptomatic close contacts of COVID cases. And that is putting a huge pressure on our staff. And I do want to take the opportunity again to thank all of our staff, our consultants, our doctors, our nurses, our frontline healthcare workers, our healthcare professionals all across the system who are working unrelentlessly, keeping those ICU beds, keeping those healthcare beds, keeping people safe in the community. And our unrelenting efforts over the past 20 months don't go unnoticed any day by any of us in management and the HSE. But the actions of the health service alone won't get us out of this current situation. If cases continue to rise, there comes a time when no additional testing, tracing or vaccination or hospital beds or ICU will help to turn the tide. So a range of actions are needed by all of us to help turn this tide and to turn it soon. And all of the solutions to get us out of this really concerning situation in the virus transmissions in the community are needed to be reignited by all of us at pace, individually and collectively. And to be very clear, unless it's taken up differently, I am not, and the HSE is not, in any way calling for a need or requirement for further restrictions. That's the role of other bodies and organisations and indeed government. And on the contrary, we know the impacts of restrictions and long-term restrictions on the economy, on the society, but equally on the health service. We're still experiencing many of the impacts of long-term restrictions. So in case there's any ambiguity, that's not what we're calling for. But I would say that there's 3 areas can help us to turn this around, and I'll briefly summarise what they would be to help us turn around these hospital numbers and the ICU. And I should recognise, thankfully, we are seeing, certainly over the last few days, beginning to look like a stabilisation. But we can never be certain with the high case numbers that we're seeing and the transmission levels in the community that will start to rise again. But we would recognise that thankfully, hopefully, that is the start of a trend. But there are, as I mentioned, 3 ways in which we can turn this around. Firstly, for those who remain unvaccinated, we remain available to answer any queries, to answer any of your concerns. We continue to see more and more people come forward for their first vaccination. We're seeing, on average, about 1,800 people a day still coming forward to register. And everybody who's unvaccinated should take encouragement from that. And nobody who isn't vaccinated at this point in time, it's never too late, and nobody is judging anybody in terms of when or how they come through for vaccination. We're there to support people and make them feel comfortable in coming forward. Secondly, is a strengthened re-engagement by all of us, as I mentioned earlier on, with the traditional and proven public health measures that make a huge difference, and people can understandably get a bit fed up with us relentlessly relaying them. But we have to keep relaying them for all of us. The social distancing, the mask wearing, the coughing and sneezing adequate, staying at home if you're feeling unwell or feeling symptomatic, and so social distancing that goes on with it as well. So they work. We know they've worked. They've proven for us at a time. And it is a time for all of us just to ask and reassess our own personal risks. What are we doing? What do we plan to do? What do we really need to do? How do we prioritise what we're doing? And if we are doing something that is in a more high-risk situation, how do we protect ourselves and our family after those situations? So I won't relay them all again. Everybody knows them, but a plea from the HSE is we believe these will work, and we believe this will help us turn it around. As part of that, I would equally make a call to business and enterprise, again, to reassess what they are doing and the level of what they are doing and the level of what it's required for them to do. So some of the basics again, are you providing safety and security for your staff? Are you providing security and safety for your customers and clients? Hand sanitizer, basic queuing methods within retail organisations in particular, and many other sectors. Just a basic question for not just individuals ourselves, but for enterprise and business. And a third area, which again, there are very early positive signs, relate to our third boosters, or both our third vaccines and our boosters, which we are actively engaged on now across, in the first instance, the most vulnerable groups of the population. And in this regard, we strongly welcome the recommendation by NIAC and the approval by government to now move towards the booster vaccines for healthcare workers. And my colleague, Damien McCallion, will give some detail on how we'll be rolling that out. But we do believe this will give our healthcare workers further protections, further confidence, and reduce potential risk situations or transmission levels to those who are vulnerable, which are our healthcare workers, our patients as well. And it is early to say, but we are seeing positive trends from those early vulnerable groups that have been vaccinated and some early benefits, which we hope sustains itself. So those are the three areas that I would highlight today that we believe can help to turn this around. Very briefly, just to touch on those hospitalizations and ICU figures, which I've given you already. But in terms of the breakdown, which we normally give of age and hospitalizations, for those over the age of 80 is 23% of the total hospitalizations. In the ages 65 to 79, 39%. In the ages of 50 to 64, 18%. And the ages of 15 to 49, 18%. And the ages of 0 to 14, 1%. In terms of ICU, age and ICU, 50 years plus, 72%. 19 years to 49, 26%. And 0 to 18, 2% of total people in ICU. And in terms of ICU and vaccination, which we report on each week, 52% of the patients currently in ICU have received no vaccination, 3% partial vaccination, and 42% have been fully vaccinated. My colleague, Dr. Colm Henry, will outline some report today from the National Office of Clinical Audit and some highlights from that report today, particularly related to ICU. And I just wanted to touch on two very brief points on it that I took out. First of all, COVID-19 patients occupied 22% of all patient days in ICU from the period of March 2020 to October 21. And this increased to 55% for all patients in ICU in the peak surge period to January and February. So just to give you the level of impact of critical care on COVID, by COVID. And 53 patients who are pregnant or recently pregnant were admitted to ICU with COVID-19 up to October 31st, 2021. 58% of these admissions were since August 2021. Only one patient was fully vaccinated, and thankfully all of those have survived to date up to October 31st. The vaccination programme, as I mentioned, my colleague Damien McCallion will bring you through some of this, but just a few brief mentions. As we scale up the booster programme, it's important to equally take stock of the current levels we're at, because we sometimes might just forget 94% of the total adult population over 18s are partially vaccinated and almost 93% fully vaccinated. So that's the level we're at. And of the total eligible population over the ages of 12, 91.9, so almost 92% partially vaccinated and over 90% fully vaccinated. And are now over 200,000 either booster or third dose vaccines have been administered. Positively, as I mentioned, we'll continue to make progress across all of those who have been approved to date. And last week alone, 33,000 primary course vaccinations were completed last week alone. So that's either a first dose or a second dose. And again, encouragingly, we're seeing a higher uptake of pregnant women. We're now at a recent survey of 58% pregnant women who've now been fully vaccinated. And you'll recall that was hovering around between 28 to 40% a few weeks ago. So encouraging news on that. I'm going to pass you across now to my colleague, Ms. Anne O'Connor. I'm happy to take questions later.
We'll talk through how the system is looking. Before I do, just in terms of the key highlights around how busy our system is, there are some things that we need to remember. So in terms of supporting our health system, both in terms of supporting your own health, but equally supporting others to be able to avail of our health service, there are some things that we can all do. So in terms of following the COVID advice and the guidelines, getting vaccinated, as Paul said, if you're not vaccinated already, please do so. Ensuring that we get tested, following the tracing. Getting the flu vaccine. We are now rolling out our flu vaccination program. Very important, particularly if you are in one of the vulnerable groups, that you would avail of the flu vaccine and reduce that risk of getting sick with the flu this winter. And finally, just keeping yourself well. So the best thing you can do for yourself this winter is to try and stay well in terms of not needing some of the services that we're about to talk about. In terms of our ED attendances, we can see there just in terms of the annual graphs, we can see 2021 has run higher in terms of attendances at our emergency departments, and likewise our admissions sitting above the 2019 and 2020 figures. When we look at what that means in terms of the past 8 weeks, we can see that our attendances are 6% down on last week and just 21% up on the same week last year. So a lot of activity going on in our emergency departments all over the country. Our admissions are 5% down on last week and 9% up on the same week last year. So a very busy system, and again, no real geographical variations, a lot of sites very busy. In terms of our attendance of our over 75s, that has been running at a much higher level. Interestingly, in the last week, it's come down. However, for all the weeks before that, you can see that red line sitting significantly higher than last year or the year before in terms of people aged over 75 attending, and our admissions equally running higher, and likewise that has come down just this week. So when we look at the last 8 weeks, we can see there it's down 8% in terms of attendances on the previous week, but up 8% on the same week last year. In terms of our admissions of people aged over 75, that's down 7% on the previous week, and again just under 8% up on the same week last year. So a lot of activity, and again we know that people presenting who are older to our emergency departments are far more likely to be admitted, every second person instead of every 1 in 4, and their length of stay will be longer in hospital. In terms of our patient experience time, we can see that that's just down slightly on the last week and down 1.7% on the same week last year. Again, this is a very important metric, particularly as we start heading towards winter and all of the discussion around winter and trolleys. The most important thing for us is to understand how long people are on trolleys for. So when an emergency department is busy, it is inevitable that we will have trolleys and people on trolleys. Our challenge is to ensure that people don't stay on those trolleys for too long, and that's why this patient experience metric is actually a very important one for our system. The 9-hour patient experience target there for over 75s is up slightly on last week, but nearly 15% down on the same week last year. So again, we're working on these, and our real task is to ensure that we maintain these targets and improve them throughout winter. Our trolley count has actually come down, so our average trolleys have reduced. We had 292 patients on trolleys this morning. Now that's up significantly on the same day last year because we had a much lower trolley count last year when people stopped attending and we weren't seeing the same level of congestion. However, it is significantly lower, so 35% lower than 2019, and an average trolley count of 304 over the past 7 days. In terms of the sites that are currently experiencing high levels of pressure, we can see some of the sites there today. So Galway at 38 this morning, that actually is lower this week. And again, I think the same thing happened last Thursday. The number today is lower than it has been for the other days this week. But Galway are seeing very significant levels of attendance, significant levels of congestion in their hospital. They've had 213 presentations in their emergency department on Tuesday. In terms of Limerick, 15 people this morning on trolleys, down slightly on the same day in 2019. Very high levels of presentation in their emergency department, so up 52 on the same day in 2019. So again, high numbers of people presenting. Likewise in Cork, 23 people this morning, up 19 people, so 232 people presenting to their emergency department on Tuesday. In terms of Drogheda, Our Lady of Lourdes, 4 trolleys, people on trolleys this morning. Again, high levels of presentation, so 50 people more attending than on the same day in 2019 at 226. The Mater, 25 people on trolleys. with just 34 people, that should be plus 34, attending compared to the same day in 2019. And then in Waterford, interestingly, nobody on trolleys there, and yet high levels of attendance with 52 people more attending than the same day in 2019. So we are seeing in a number of our bigger sites, our Model 4 sites, significantly increased levels of attendance in our emergency departments. And obviously when you're balancing that then with the COVID pathways and all of the challenges that presents, we can see our hospitals are very busy. Our delayed transfers of care are being maintained under 500, so 477, significantly lower than 2019, higher than last year. Last year we had a very marked reduction in our delayed transfers of care, and we are maintaining that. Thankfully, it hasn't grown in the last number of weeks. It's still under 500. And obviously, again, that's a real priority for us in terms of patient flow and in terms of us using all of our bed capacity to best effect. We've talked about the hospitalised COVID cases, so 458 today. That's down on the same day last week, down 6%. And when we look at the daily confirmed admissions, we can see that over the past 2 weeks, the trajectory there is one of where it's come down. It was significantly higher there back on the 30th of October at 55, up to 36 today compared to 31. So just, that's up and down in terms of the daily admissions of people with COVID into our hospitals. Likewise, ICU admissions, a very jagged graph, 8 in terms of the daily admissions today, up from 6 yesterday. Paul has already mentioned the age profile, mostly over 65 there, so over 50. There are 65 people over 50, and between 19 and 49 with 24 and 1 under 18. And the vaccination status equally, Paul's already referenced there. So 47 of the people currently in our ICUs are not vaccinated, with 39 vaccinated and 3 partially vaccinated. So again, a very disproportionate impact in terms of the number of people coming through from a much smaller amount of the population to our ICUs who are unvaccinated. When we look at our ambulance activity, we can see the chart on the left there, and again, these are busy slides, but the chart on the left is showing the activated calls running within the lines, so between the 2 red lines, running pretty much in line with what we might expect. It did peak at a higher level in recent weeks, but again, back into kind of more in a predictable fashion. However, when we look at the chart on the right-hand side, this is the number of people being transported to our emergency departments by ambulance. That is much higher. So that is running at a much higher rate than we would have predicted. Again, our NAS predictions are very accurate in general. It's something that we do rely on in terms of looking at our system. And obviously, the ambulance service is a very important part of our unscheduled care pathway. So that we can see there that the level of activity bringing people to emergency departments is running at a much higher level. In terms of outbreaks, we can see across all that we have 17. So in terms of outbreaks across all facilities, 17 in terms of our long-term residential care and 10 in hospital over the past 7 days. I know Colm is probably going to talk more about this, but we are seeing a level of outbreak, albeit reduced case numbers in terms of the numbers of people impacted by the outbreaks. Just want to mention waiting lists, and I did talk about waiting lists last week, but we now have the full month of October's data there, and we can see that in terms of our inpatient and day case on the left-hand side, that is down, so 0.3% on October 2020. So we have actually started to reduce it down a bit, now a small reduction. It's up on 2019 figures at 10.6%, but bear in mind that since 2019 we have had all of the COVID surges and the cyber attack. So at least now we have seen it start to turn down a bit. In terms of our outpatient, this is the biggest number. So we have an increase of 6.8% on October last year, so that hasn't started to come down. In a year now, we are seeing a lot of improved activity around the country in terms of our outpatient activity, and it's up 14.7% in October 2019. In terms of our scope, so these are endoscopies, colonoscopies, etc., down 9.4% on October last year. So again, a lot of activity going on to try and address those waiting list. Scopes are very important as a diagnostic tool in particular for people, and very important for us to be trying to get to those in a timely way. So we are seeing a slight reduction there on the numbers waiting, although it is an increase in terms of October 2019. So a lot of work, and I won't go through all the detail of them today because I did that last week, but just in terms of a lot of work going on, as Paul said, really trying to get to the end of the year with a marked, I suppose, turn in terms of ensuring that we're not growing those waiting lists, because the first step for us is to stop that growth and to be able to deal with everybody coming through the doors and then start to address the backlog. Just some stats here in terms of our community services, and obviously we spend a lot of time talking about our emergency departments, but our community services are hugely important in terms of our 9 community health organisations supporting people to stay at home and providing a lot of interventions to people who will not need to come across the hospital services at all for these things. We have our community intervention teams which do support hospitals, so support people in terms of a more acute discharge pathway. And we can see that in terms of referrals, nearly 49,000 referrals year to date, and that's nearly 9% above the expected year to date activity. In terms of our palliative care beds, we continue to work and to improve access to palliative care. 98.8% of admissions or referrals to our specialist palliative care inpatient units are now admitted within 7 days, and that's against a target of 98%. In oral health, 86% of new patients commence treatment within 3 months of scheduled assessment, and that's against a target of 90%, so slightly below. CAMS, which is a very busy service, 75.8% of referrals accepted by CAMS nationally were offered an appointment within 12 weeks, and that's against a target of 78%, so slightly below target. However, 94.3% of urgent referrals are responded to within 3 working days, and that's very important. So in terms of urgent cases being seen within 3 days, we are achieving the target on that. 2 important initiatives in terms of improvement initiatives in community services. One is our speech and language therapy access, and that has improved. So for people, 36.4% decrease in the numbers of people waiting assessment for longer than 52 weeks. Now, 52 weeks is obviously a very long time for somebody waiting for an appointment, but that is currently what we're working to in terms of targets. And we have a significant improvement programme underway on that. And critically, our assessment of need initiative, and I've mentioned this here before, we've had an improvement project running for assessment of need, and this is for children with disabilities needing assessment under the Disability Act. We've had a very significant backlog. So we had a backlog in June of 2020 of 6,558 children awaiting assessment. That is now down to 518 in September. And nationally, 92% of all overdue assessments have been completed. So very significant progress. So notwithstanding all of the other pressures across our health system, it's important to note that there's a lot of really good work going on in terms of this, the primary care-based therapies, and again, supporting people, children, families to stay well at home and to access the services and the multidisciplinary services that they need to access. So I will leave it there and just reiterate Paul's thanks to all of our staff working all around the country who continue to work day in, day out in terms of addressing all of the many challenges that we have providing services to people now and for the rest of the winter. Thank you.
Thank you, Anne. I just want to go through some of the current disease indicators as they pertain to the numbers of cases, the trends, what's that mean, and their conversion to harm in the form of people who become ill, hospitalised and require intensive care. So this graph shows that surge of cases we remember in January at the time when we had no, the vaccination programme was only beginning, that the only really weapon against COVID-19 and the transmission of cases were those social restrictions that we're all so familiar with. We saw was a rapid rise during January and a rapid fall, mainly due to the social restrictions, the distancing, and everything else that people are familiar with. But the more recent surge is different in shape, and that's on the right-hand side of the graph, where you see a longer, slower upslope and a consistent number of cases rising gradually over the past few weeks. And that, if you see that 14-day instance, 1,492 in January, it peaked at 667 now. But the average number of cases per day over the past few days has been now approaching 2,800. And back in January, at a much more vulnerable time, it was nearly 7,000. Likewise, the hospital admissions has been referred to back in January, nearly reached 2,000, but at a time when we can configure our health service almost to deliver urgent emergency and COVID care alone because of the degree of cancellations and the curtailment of other services. Now we're at 458, ITU admissions now at 90. So it's a different shape now, and that's because of the vaccination programme and the protection it gives us from serious illness. But that protection isn't limitless. So new cases of COVID-19 have risen in the month of November from a weekly average of 1,493 at the start of September to 2,600 now. That's the top graph, gradual rise in number of cases. Blue graph in the middle shows where we are at hospitalization, a gradual rise, but some stability over the past few weeks. but at a time when we're delivering the full range of services as described by Anne, and we're trying to catch up with waiting lists and also keep up our targets with respect to some time-critical conditions, such as people awaiting treatment and assessment of cancer clinics. And the bottom black graph shows those in ITU, again creeping up and stabilising, but again at a time, as has been mentioned before by Paul and others here, at a time when we're delivering other services dependent on ITU, that trauma is coming in, more trauma now that there's severe trauma now that society is reopened, more people with severe illness, and there's very little room outside those 1 in 3 beds occupied by COVID and all the other people who need treatment in our intensive care beds. Looking at intensive care, what's the profile? Well, on the left-hand side, we looked at all patients admitted with COVID to our intensive care units in Ireland from the 1st of April right through to the end of October. And you can see that 64% of all ICU admissions occurred in people who were unvaccinated. So they're completely disproportionately represented in terms of those who became critically ill. And then, of course, people ask, what about the breakthrough infections? Of course, breakthrough infections will happen, and they happen because no vaccine is 100% perfect or effective. And secondly, the more cases you have in the community, the more cumulative number of chances there are for somebody who's vulnerable to acquire the virus, become infected and become sick. And we see a growing number of those proportion become of ICU admissions in fully vaccinated people as our population and target population becomes more fully vaccinated. But the great majority of those, of the 137 patients who were admitted to ICU since April the 1st and who were fully vaccinated, 98% had an underlying condition. Hence, and that underlines the importance of this booster campaign. It protects people with underlying conditions, those who are vulnerable, whether due to age or underlying conditions, from serious illness. And the most serious manifestation of that illness will be the kind of illness that needs intensive care. And we've referenced already, and Paul has referenced, that this is a kind of a heat or thermometer, if you like, of how severe illness in our hospital setting. Back in January, when we peaked at 220 people admitted, 220 patients at one particular day in our intensive care units with COVID-19, and a total of 340 people needing intensive care for all conditions that day. We had, in addition to that, over 400 people out in the wards receiving high flow oxygen, or what you see in the picture here is this non-invasive ventilation. Some people may be familiar with this. They may have visited people in hospital. This is a very uncomfortable a form of treatment that necessitates giving oxygen, high flow around a mask that's pressed tight to the face. And it's a form of treatment that's given in hospital wards from day to day, but we had increased numbers given during that surge of cases in January. And again, we see creeping up now the amount of people receiving this kind of additional intensive supported care in ward situations with the appropriate staff, nursing and doctors supervising it. That's now up to 293. Now, looking at hospitalizations, I just want to look at we've been talking about hospitalizations and admissions to ITU, and you can see the 53%. Just over 50%, 50% of hospitalizations in the last 2 weeks are in the over 65-year category. So that remains the single biggest risk in terms of getting ill from COVID-19 is age. And we can see that very small numbers of cases in younger age groups. But then when you look at the cases, the bars all shift to the left. The great majority, 47% of cases in the under 35 age category, yet the great majority of those, if you see the previous graph, don't translate into sickness. So there is this differential in that cases in older people are more likely to translate into illness. Cases in those who have underlying conditions more likely to translate into illness. And cases, thankfully, in young people and children, much less commonly translate into illness that necessitates hospitalization. At this point in time, for example, in our children, the greatest threat to their welfare in terms of hospitals and ICUs are other seasonal viruses that we're well used to over the years, such as RSV. These are other measurements we brought forward over the past few months. You may be familiar with. The left shows hospital-acquired COVID cases, people who acquire COVID in hospital settings. That peak at in January, week 2, shows the number of cases we had in January very, very high. And thanks to the efforts of infection prevention control teams, our staff, the PPE they wear, the hand washing, and of course them getting vaccinated themselves, we see much lower levels. Despite the high level of community transmission at the moment, we see that translated to much lower levels of acquired COVID in a healthcare setting. And similarly, the outbreaks in the middle graph, much lower than they were in January, again, thanks to the work of our staff in all those efforts of infection prevention control and in the vaccination programme. And on the right-hand side, new cases in hospital staff, which led to a level of absenteeism due to illness or close contact designation back in January, which really threatened the stability of hospitals and nursing homes throughout the country. Again, at a lower level now, which is certainly one of the brighter aspects of the most recent surge, is that we seem to be holding that protection tight, although eliminating it to zero is very difficult with the current levels of circulating virus. And as alluded to, the outbreaks, 6 in nursing homes past week with 15 cases, relatively low number of cases per outbreak, hospitals 6 with 29 cases. So these outbreaks are much less serious, not just in terms of the number, but in terms of the impact, in terms of people who were affected and in terms of how severely ill they were. And this shows us in a nursing home example. The pink are nursing homes, the dark purple are community hospitals, and this latest surge on the right-hand side shows a much lower level of outbreaks in nursing homes and community hospitals. So where's our position in Europe? The 14-day instance just there, but it's 8th or 9th in Europe. And the ECDC have done an assessment of the current state of concern in Europe, and they're looking at 14-day incidence rates, many countries going up, weekly hospital admission rates, many hospitals going up, weekly ICU admission rates, many hospitals going up, and sadly, an increased death rate in many countries also going up. So certainly of at least moderate concern for them in terms of case numbers and their translation into harm. And the harm bit, that flood wall that has helped us is, of course, the vaccination programme. And we now have a situation where of the 18-plus population, 92.7% fully vaccinated and 94% have received over 1 dose. And even of the eligible population, we've at last crept over 90% in terms of coverage, which is puts us at the top of the European League in terms of countries fully vaccinated per adult population on the top right-hand side of the graph there. A couple of points I want to make about vaccination, because there's been much discussion on that over the past few weeks. It's very effective at reducing serious illness, but it is less effective at reducing transmission. This study came out in the past week showing that for COVID-positive cases that came into households, for example, there's still a 1 in 4 chance of household contacts becoming COVID-positive from such cases. This was lower than people who were unvaccinated, but nevertheless, it shows that that unvaccinated people can't rely on the immunity of the vaccinated population for protection. They remain susceptible to infection and risk of serious illness and death, and that's why continued public health measures are important. So vaccination reduces but doesn't eliminate the risk of transmission from cases that come into the house. But if you were vaccinated, you're less likely to acquire the virus, but you're still a relatively high level. And why is that? Well, we see high levels of nasal virus. It falls more quickly in vaccinated people, but nevertheless, that underlines the fact that it may still, vaccinated people may acquire the virus, may not become sick, and may transmit it. Looking at the third dose, I just draw your attention on these graphs to the red and the blue. And you can see this red is where things would be in terms of admission to hospital on the top, or severe COVID on the bottom after 2 doses. But the blue is where things go after 3 doses, with a big reduction of over 90% in severe illness and 81% in preventing COVID-related death. And that's why this booster program is so important for vulnerable people. And there's further studies which have shown this waning immunity after the second dose of the Pfizer vaccine happening after a number of months, and again, which informed the NIAC decision to roll out this booster program, which we are doing now, not just in terms of residential care facilities, but in terms of those over the age of 60 and in healthcare workers. This study from South Korea underlies the importance of getting a flu vaccine, that those are prior influenza vaccine, some higher risk of COVID-19. So to echo Anne's message, really important that anybody eligible gets the flu vaccine. So core messages, number one, our healthcare system is significantly stretched. due to the number of cases of COVID-19 and the morbidity, illness associated with that and with other seasonal viruses. Second is our provision of intensive care is under considerable pressure, with an increased need for supportive care outside intensive care settings. Third is unvaccinated people don't have any protection from the virus. Unvaccinated people can pick up the virus from vaccinated people, and unvaccinated people who've recovered from COVID-19 have less protection than vaccinated people and can still be reinfected. The fourth thing I'd like to say, vaccination alone will not control case numbers. Public health measures, particularly staying at home if you have symptoms, remain critical to controlling case numbers and the harm that results from those case numbers. Next, vaccination remains protective in reducing serious illness, but waning immunity necessitates a booster campaign for specific groups to ensure at-risk groups are protected. And lastly, to reiterate that message we've learned from the very beginning, is prevention of COVID-19 is much easier than treatment by the time somebody goes into hospital, requires non-invasive ventilation or still invasive ventilation. At that time, it's much more difficult to treat. Thank you.
Good afternoon. Just going to give you a brief update in relation to the testing and the vaccination programme. So just on testing first. So the testing system, as Paul has said earlier, like other parts of our health system, is still under pressure. If you look at the numbers that are there, the 132,000 community swabs taken last week, that's an increase of 16% in terms of swabs, and we've seen over 20% increase in referrals. So others have referred to the impact of that. Total number of laboratory tests is 167,000. Those are huge numbers relative even to where we were at earlier stages in the response to the pandemic. So we are certainly under some pressure, but we are coping with that pressure at the moment, and we're continuing to try to introduce initiatives, I suppose, to ease the strain in terms of the testing and tracing system through further automation. So we have automated our call 3 this week. We've introduced the NEFIT guidance in relation to the antigen testing for vaccinated, asymptomatic close contacts, and we've seen a good uptake on that, around 1,000 a day. That just kicked in tail end of last week. So overall, the system is under pressure. We are seeing big increase in demand as a result of the cases that are out there in terms of the transmission of the disease, the column and others have referred to. But as I say, the system is coping, but it is certainly at full stretch at the moment in relation to the capacity right across the pathway. What's probably important to say is that the testing and tracing system, what it will do is it will see some slight deterioration in performance. There isn't a sort of breaking point as such in terms of a magic number, but obviously we monitor that to make sure that we're continuing to hit our targets, which we're continuing to maintain by and large at the moment. Then on the vaccination programme, and just to reiterate, column slide, it's really important. You know, the uptake that we have, and column has referred to it in terms of the percentages that we've hit in European terms are very high. So when we look at uptake improvement initiatives, which I'll come on to, they need to be seen in that context in relation to where we're at in terms of both first doses and second doses. So broadly speaking, and I won't go through all of these, we've talked about our uptake initiatives over recent weeks, and we're continuing to prolong that initiative to try and encourage those people to come forward for the reasons that Colm has said, for their own health, for their family's health, and for the wider benefit for the population. So at the general population level, we continue to run national media campaigns across the country in terms of radio advertisements and also in terms of particular targeted campaigns. And Paul referred to it earlier, we're continuing to see good progress in terms of what might seem very small numbers relative to we were at the early stages of the vaccination programme, where we're doing hundreds of thousands in a week. But in terms of first doses, those sort of numbers, those 1,500 people are really important, because the more of those people that get done, the greater the chance that less of those people will end up in ICU or in hospital. So again, just a number there, over 5,000 over the last number of days. But overall, we're still seeing that up to 1,800 a day on average coming through the various initiatives. That's very, very important. Equally within that, the percentages, I suppose, do mask. There are certain groups that we really want to encourage to come forward. One was pregnant women, where there was a lot of work done with our clinicians, hospitals, and also with people who are pregnant and their partners. And we've seen some really good improvement. Our Women and Infants programme, from a study done last week, 58% of the women have now confirmed that they're at a vaccinated status, full vaccinations, and 75% of their partners. And that's a good jump from where we were. So that's really important. And again, we would encourage people to come forward, talk to their clinician. Everyone understands that it's a big decision for people, but have that conversation and hopefully they can guide people through that. Equally then, in terms of some of the other vulnerable groups like the homeless, we've again been continuing to try and work with those groups and other such groups that are disadvantaged. And I'll come on to some of the migrant communities in a moment. Low uptake areas, we know there's some counties where there is slightly lower, notwithstanding the high numbers that we have in Ireland relative to other parts of Europe. And we've now gone in, apart from the counties that I've mentioned there, we've gone into what's called local electoral areas. So within a county, by working with the CSO, we've been able to identify where there might be very specific areas where there's small uptake. And we're doing two things there. One is working with pharmacies, running promotional campaigns down to bus shelters in particular, advertisements in certain areas, but also more specifically as well, there are pop-up clinics being operated in some of those areas over the coming weeks just to try and encourage access alongside the information. And again, the pharmacy sector has been really invaluable in this. They exist throughout the country, and we've worked with those pharmacies in those areas and more generally to try and again provide access to people to come forward. And some of those people that I talked about, the 1,800, are coming through the pharmacy sector as well. Workplaces again, and in some cases this links into other migrant communities where there are migrant workers, for example, big numbers in the food industry or the meat industry. And again, with public health teams locally, they're doing Trojan work to try and encourage people to come forward, specifically in terms of offering on-site vaccination in some cases, bringing in people who speak the language, clinicians perhaps who speak the particular language involved, alongside all the other multiple channels that we're using in multiple languages. There's over 35 languages now in terms of where information is, or videos and so on. We've put advertisements in local Irish, Russian papers, Lithuanian papers, and other things like that. The walk-in clinics Paul referred to earlier have been really good, very successful for the higher education. That initiative brought in another 5,500 younger people. And again, you can see the numbers there in terms of the walk-in clinics. As we move into the boosters now, we'll lean more into the pharmacies. But we have, as I say, had real success with those walk-in clinics. And lastly, the migrant communities. We're working with some of the NGOs to try and look at the various networks they have to encourage people to come forward. We do know that in some of people's home countries, the uptake in some cases is very low. And we're trying to strive, I suppose, to improve that through some of the initiatives that I've set out here, the Irish Immigration Service, and also multilingual communications. So just moving on then from the sort of first dose and second dose of primary dose in terms of the programme, which will continue. The immunocompromised, again, good progress, estimated to be 75 to 100,000. Very complex group to identify. Big ask of our hospital system and our GPs at a time when they're very busy, as Anne has said earlier. Referral pathway was put in place, around 81,000 people already identified, 48,000 doses administered, and again, significant number of appointments. And the reason the appointments are larger is some people obviously require 2 or 3 appointments in terms of before we can finally get them through in terms of vaccination. So look, good work through GPs, but particularly our hospitals to acknowledge that in light of the pressures that Paul and Anne and others have set out earlier. The booster programme, just a very quick snapshot of where that's at. So the first piece of advice, as Colm said from NIC, was the over 65 and long-term residential care. That's now substantially completed. We do have other people to go around where there were outbreaks or where someone maybe had a medical issue and couldn't be vaccinated at that point in time. And that was also only for the over 65s. We will be coming back out now following recent NIAC advice to offer that service as well, the vaccination to people between the ages of 60 and 65 also. The 70 to the 80-year-olds, if I move on to that next, 161,000 been done through general practice. Again, phenomenal progress, 142,000 done, and the plan is to complete that in November. And we've also opened up our home vaccination service. People may remember that for people who are housebound, where GPs can refer in, and clearly that's a very important service as well for people over 80 years of age. The last piece of NIAC advice then prior to healthcare workers related to those aged 60 to 80 to 79. So the 70-79s are going to be targeted through general practice. That's starting, expected to complete in around about 4 to 5 weeks. And again, as I say, 336,000 people in that group. And general practice were really successful in our first round. And again, we would be very positive, the early indications from the over 80s. And again, even from discussions around the 70-79s is that does facilitate a high uptake amongst some of the most vulnerable groups. As Colm said, the age has a relevance in relation to the impact on someone if they happen to get COVID. 60 to 69, a large population, 475,000. That will begin this week. Talking to someone just before we started. Her mum had got an appointment for tomorrow, And so that's starting again in terms of the vaccination centres, and we'll drive that through. We made a strategic decision to retain the vaccination centres. Some countries didn't do that, primarily to try and ease the burden on primary care, but also, I suppose, to try and ensure we get an accelerated implementation of the vaccination programme and of the boosters. And again, that will run through towards the end of December. One important difference between the booster campaign and the initial primary campaign is that 6-month guidance. People must have that recommendation of 6 months and a minimum of 5 months between their vaccines. So we have to manage that. So that will mean in some cases we have to spread out the allocation of appointments based on when people were originally vaccinated. And finally then, in relation to healthcare workers, this advice was just received on the 1st of November. We've been working on this in the background to our operations people and all of the team in our National Immunisation Office and other areas. So overall, that group is around 305,000. Again, bringing out the long-term care facilities as the LTCFs. It will be offered again approximately 6 months after their second dose. Most healthcare workers will be invited for their vaccination at a vaccination centre. That's going to be the primary channel to try and ensure we get to people as quickly as possible. Pharmacies will be coming on board over coming weeks as well to offer that and to support the programme, and we're finalising some details on that around the technology and other things that we need to put in place for that. And finally then, there will be some people who have recently become healthcare workers. So we have a strong database, that 305,000 of all those frontline workers. Any new healthcare workers that came in, there was a process to bring them on board over the last 6 or 7 months. But there will be some people perhaps who were vaccinated outside the healthcare workforce, and we will put in a facility to allow them to identify themselves in due course. Anyone over 60 will be included in the age cohort. They're going to be swept up quickly there as well. So again, in terms of timing, it will really be contingent on when people had their second dose. So we'll have had healthcare workers vaccinated in September, August, and so on, back through the months. But the vast majority will be got through in around a 4 to 6 week window based on when the original vaccination was. And then we will still have, obviously, an ongoing process from there right through into Christmas and probably into next year as well, based on when people were done. Thank you.
Thanks very much, Damien. And now we take some questions. If you could identify yourself and your media organisation here and here.
Stephen Murphy from News Talk. Paul, I suppose there's a lot of concern, obviously, about the high case numbers at the moment. People are worried about whether the vaccine and the protection is starting to wane a little bit. And NEFID obviously saying that people should cut their social contacts. But clearly, you know, there is some hope that the hospital numbers are starting to level off a little bit. So do you think, you know, there's a need for people to be alarmed at the moment?
I think, as I said earlier on, Stephen, it's a welcome to see that hospitalizations at least stabilised during this week. It's too early to say that that's a trend, because we know from high case numbers over the past few days that has a lag period before we could see increase. So we've been hovering around 500 now for a sustainable period of time. The particular concern is the number of people in ICU. It's 90 people right now as we speak, and that's taking up to a third of our ICU beds in any given week. So our concern is, A, that it's impacting on non-urgent elective care, all of those beds who we have to treat people for COVID. And secondly, that we do see a rising transmission levels, or growing transmission levels in the community, and what we may see in hospitalizations. What I did say earlier on, I'm convinced are 3 areas that can get us out of this. And one was most definitely the stronger re-engagement by all of us and the public health measures, and I won't list them, but equally making a judgment call about what do we plan to do over the next few weeks, what do we really need to do, what should we do, and how we protect ourselves at any of those events or locations we're going to, how we protect ourselves at the event and post the event for our family. I think all of those initiatives work. Secondly, in relation to unvaccinated people, we know by bringing more unvaccinated people through, we can give greater levels of protection, particularly to the percentages we're seeing coming through to ICU. And thirdly, in terms of what you just spoke about, reduced immunity, obviously based on the decisions of NIAC, there are concerns about reduced levels of immunity for vulnerable groups, and that's what we started with. And there are early indications that can prove beneficial.
And then can I ask about just the antigen test being sent to asymptomatic close contacts, people who are fully vaccinated? Do you have a target for how quickly you're getting them out to people? And is there any early findings of how many of them have come back positive since that started?
Yeah, so in terms of the timescale, effectively, look, we're trying to get them out through next day. They're posted out, so people go in now. It's an online system, and they register their arrest, and they're sent out immediately, and they're posted out a number of times a day. So typically, it's next day, but maximum of 2 days, which would be within the public health advice. It's around about 1,000 a day at the moment. We'll see a little spike in that. I talked about the automated system that will probably, by speeding up some of the people that are in the queue at the moment, will lead to a little bit of a spike in that. Overall, in terms of the positivity, it's a little bit early to say. We've certainly seen some positive tests back already. People register the results online, so they've only started. It went out, say, just over 6 days ago, so it is pretty early in relation to trying to give any indication on the positivity side. But we'd hope to have something by the end of this week. But broadly speaking, I think we've around about 1,000 results already recorded, and it's a relatively small number of positives so far. But we'll have a better sense, I suppose, when it's operating in full for a week, of what the numbers will look like.
30,000 people who have registered their antigen test with us now, separate to the close contacts, vaccinated, symptomatic or unsymptomatic people. So, it's a lot of registrations going on with it.
Realistically, people probably only record their positives in the main. We do get a small number of negatives, but as you can imagine, if someone gets a negative result in an antigen test, they're happy it's a negative result, and they move on and they take their second or third test, as the case may be. So it's very early yet. But so far, I think, we also have support for people from HSE Live. So we've had calls through and people have been talked through, if they're not familiar with an antigen test, there's materials online and so on as well for some of the close contacts. But as Paul said, the portal is open to everyone to record results. So it's given us a good sense of the use of the test and what the results are. And then that allows you then, in the case of the vaccinated asymptomatic close contacts, to go for PCR. If you record a positive result, then you can go and get your PCR test for confirmatory purposes.
Just in terms of the contact tracing in schools, we know that's being reviewed at the moment. There might be some parents worried about, their child potentially is a close contact. Coming up to Christmas time, they might be meeting up with vulnerable family members who might not have had a chance to get their booster yet. So I don't know, do you think that it's potentially something that might need to be brought back in?
Two aspects to the contact tracing. It was we carried it on among asymptomatic children who were close contacts for over 3 weeks in September. We found during that period of time, we did 70,000 extra tests than we've actually done, would have done if it hadn't been there in that system. And there's positivity, that rate was 1.7%. So the pickup rate among close contacts in the classroom setting, even in the midst of the Delta virus being the most prevalent, was quite low compared to the household setting, where the positivity for close contacts is over 30%, 35%. Secondly, I would say that we know that serious illness, thankfully, among children is very rare. We have classrooms are not sterile settings. We have had children who have been hospitalised. We've had a small number who have been admitted to ITU. Thankfully, none have died. But as outlined in my presentation earlier, the great majority of morbidity of sickness and serious illness is among younger people, older people, or those with underlying conditions. But like anything else that has happened throughout this pandemic, it's important we continue to look at patterns, outbreaks in schools, the numbers in children, not just numbers of cases, but sickness as well, and transmission patterns. And certainly the opinion of public health teams at this point in time is that the cases that we saw in younger people rise in recent weeks has been more likely than not been due to acquisition in the household setting, where the transmission rates are quite effective and efficient compared to the classroom setting. But like anything else, Stephen, all these things are always kept under review.
Hi, Michelle Hennessy from the Journal. A question on testing first. Damien, you said that there's no magic number in terms of capacity, but you did mention getting to a stage where there's a deterioration in the service. So how close are we to what you would describe as an unacceptable level of deterioration in the service? And do you think that we're at risk of having to change the criteria for testing, or maybe moving back to GP referral only, so that you're definitely getting all of the people who are symptomatic in first?
So I suppose our surge capacity is over 20,000, and that's sort of, again, reasonably flexible in terms of numbers, a little bit. But clearly there's a point you get to where, as I say, you will see some change in terms of the performance. But that's a gradual thing in terms of how that's seen. I suppose automation on our contact tracing side will hopefully help to assist with that, both in terms of responsiveness quickly, but also in terms of capacity, because clearly if you can automate some of the processes, it makes it more efficient. And there was a lot of work really underway over the last number of months to do that. And as I said, I mentioned our process around the automation of some of the close contacts in terms of their testing process, and that's just gone in this week. But again, that would have been worked up over quite some time. In terms of the system, I suppose, in terms of the strain that's there, clearly the more positive cases that come forward, it impacts on contact tracing, but the more prevalence of the disease in society and the more symptoms we have coming into the winter period with flu and so on, that would be a concern we'd have looking forward. I think we have a very small number of flu cases. Yeah, Colin could talk to that, but if that increases and people feel the need to test, so that is a tension, there's no question about it. I suppose, at what point does that service get affected to the point where it's deteriorated, where it impacts on society? I suppose the first thing I would say is that if people are symptomatic while they're waiting for a test, they should stay at home. They need to follow the public health guidelines. That's what they should be doing. So in some ways it shouldn't arise if that's followed through. But obviously we know that, behaviours, there will be that can still be a problem. And secondly, then in relation to the contact, we've automated, the team have automated a huge amount of the processes. So that is assisting to mitigate. But it is a strain. There's people are working really hard out there to keep a bending. And as I said, if you look at the numbers, they're increasing week on week. I think it's 151,000 community referrals last week. The positivity has increased from September there, looking at it, about 7% up to nearly close to 16% on average. So, all of those things will continue to add pressures. Is there an absolute point where you say, look, it's gone beyond clearly if it keeps going, and we talked about the winter, that would be the anxiety we have in terms of where we get to. But we've built up that capacity. We are in surge as we stand today. So, there is a strain there in the system. There's no question about that at the moment. And that's something I suppose we try and manage, and the team manage out in the locations, in the swabbing centres, in the labs, in the contact tracing. But there is a breakpoint, I suppose. The laboratories have lots of capacity, so that's a help to us. But equally, if this was to keep moving at the rate it's moving, and you look at the winter, that would present a challenge.
And then on the booster program, we've heard from some pharmacies that they have a surplus of vaccines and they're not getting the appointments, the first and second doses. They're obviously not part of the booster program at the moment. Is there a plan in place to bring pharmacies into that booster program?
Yes, I mentioned earlier that we're in discussions with them at the moment in relation to, there are some technical changes and other things that we need to bring them on board. And the plan is to bring them on board as part of the healthcare worker program. So I'd be hopeful over the coming weeks that we'll be able to nail down a date on that. And they've been very successful. They've probably done over 300,000 vaccines in the initial primary campaign. Obviously, they offer advantages as well in terms of accessibility. So yes, we're working with the pharmacy sector to do that. And I'd be confident we will have them on board as part of the healthcare worker program over the coming weeks.
This is probably one for you, Paul, on PPE stocks. Can you just give us a bit of detail on where we stand coming into the winter when we're probably going to be in another challenging situation? Are we prepared for that in terms of PPE stocks? And there was an audit last year that recommended implementing proper systems at warehouses to ensure that we're receiving exactly what we ordered. Has that been put in place?
On the first part of your question, Michelle, we sufficient stocks to see us through winter. We had a quite significant stock built up through COVID. Indeed, we were supplying masks up to including recently into the third level education sector. So we've a strong supply line overall. There was a wider audit around KPMG audit. That's the one you're talking about. Yes, we have a range of actions coming from that, tracking a range of actions that have arisen from that audit, including in the warehouse and the management of the warehouse and stock checking and QA coming in. So yes, there's an oversight process of all of those actions at the minute. But sufficient stocks, very strong supply lines of stocks heading into winter. And positively, a lot of Irish Indigenous industry has now increased its capacity and capability to supply. So better supply lines here.
Rowan Smith from the Irish Daily Mail. Just a quick question. Are we going to reintroduce this serial testing for healthcare workers in hospitals?
Do you want to comment on serial testing for healthcare workers in hospitals?
No plans at the moment. The vaccination program is the most important. In terms of, if you look at the series of the hierarchy of effectiveness in terms of public health measures for healthcare workers to protect them, patients and the services, by far the most important is vaccination. And then booster doses, of course, have their waning immunity. The PPE and infection prevention control measures I highlighted earlier on. If you saw the huge fall in cases, new cases among acute healthcare workers and outbreaks, and that's vaccination plus the IPC and all that learning that's taken place. We did do serial testing, as you know, we've done it in nursing homes too, very low levels now in terms of the yield. So if you look at in terms of priority, the priority now is to vaccinate and get the boosters out to healthcare workers and address any remaining unvaccinated healthcare workers. That's by far the greatest priority. And if testing has a role in that, in terms of after that, well and good. But at the moment, that's the priority.
Can I just get a point of clarification on the numbers? Damien, you said there was about 305,000 healthcare workers to get boosted. I was just checking up the vaccination system there. It says in cohort 2 there was 270,000. I was wondering where the gap is there.
That in the cohort 1 there's both residents and workers in the first cohort. So when the programme started, it did both residents and workers together. So they're in that number. So when you take the long-term care workers and the cohort 2, that's where the 305 comes from.
Beyond the HSE, as private practice as well.
And just, is there a rough estimate available about the amount of elective surgeries that have been cancelled since the start of September? And do we expect more to be cancelled in a few weeks' time, coming months?
A number, so we know that we've about 21 hospitals that have cancelled procedures out of 6 of the 7 groups, so that we don't have a number on it. But yes, do we expect more to be cancelled? We do, absolutely.
Hi, thank you. Hi, Niamh Griffin from the Irish Examiner. Just on the serial testing, I thought Minister Donnelly said earlier in the week that serial testing would be reintroduced in nursing homes. Is that changed now because of the booster campaign?
So I suppose, I think, yeah, the serial testing, we had discussions with the department this morning in relation to that. That was serial testing in nursing homes. And we still have a programme rolling in nursing homes. So we would still have over probably close to 100 nursing homes still on our residential, the residential care programme. And I think that was in relation to expanding it. So we're in discussions with the department at the moment in terms of implementing that. But as I say, the priority really in the short term, as Colin said, is the booster programme in all residential care settings and for healthcare workers. And we'll work with, as I say, with the department in relation to the wider expansion. But our serial testing programme still continues, and the way that it operates, it's based on public health criteria, in other words, around outbreaks and cases, and it's prioritisation, I suppose, rather than a blanket programme. So,
Sorry, we're working very closely with Nursing Homes Ireland and Tide Daily, so where there's a request or a specific request, we're fulfilling that request as well.
In terms of, the hierarchy of effectiveness, if the purpose of this is prevent cases and illness and outbreaks in nursing homes, vaccination and boosters are way ahead of anything else. Clearly, they're practicing their infection prevention control and so on. But serial testing was something we did before the vaccination programme went into it to a certain degree as a control measure to try and identify cases and bring them out. Vaccination is an absolute priority there, and getting the booster campaign finished in residential care settings is our priority.
Okay. Thank you. And can I just ask a sort of non-COVID question? There was some controversy this morning over what seems to be a letter saying that hospital consultants would have to agree to the terms of this launch-to-care contract before seeing it. And I know there was a tweet from the HSE saying maybe has that letter been misinterpreted or...
It's great to get a non-COVID question anyway, that's a starting point. But just to acknowledge, look, firstly, we acknowledge that the recent correspondence from ourselves may have caused some confusion and indeed some frustration. And we are issuing some clarification on that today, if it hasn't already issued. The purpose of that communications was we had a concern that a lot of the services were holding back on recruitment of consultants and waiting for a potentially new consultant contract. And we wanted to ensure that they were continuing to recruit and not waiting. And part of that was a clarification around an implementation date when that emerges, or when that emerges through negotiations and discussions, that things would change post that implementation date. But up to now, people should keep progressing and keep moving on. So clarification should have issued today, certainly issuing today. It hasn't issued already on that. But that was the purpose of the communication, to keep things moving and so people don't stop. And if you need clarification, we'll set all that out. I will just say very briefly, Niamh, just at the end, while it has caused a level of confusion and frustration, which we acknowledge and we'll clarify it, there's a level of, attack on our HR director through social media, which is completely inappropriate and unfair. And, that's not right either and shouldn't be tolerated. And, we'll address the issue. But, an unfair targeting of a, senior manager is inappropriate. As always is by a smaller number of people. I'm not generalising, but it's still inappropriate.
Okay, thank you. Just one last question on the booster programme. A small number of GPs are not offering the boosters to over 70s. What's the advice for their patients?
Previously, and we'll do this time, as we have a referral pathway for people where GPs who aren't participating, and there's a huge number participating. So I just want to acknowledge again the support of general practice. They've really been phenomenal right through this vaccination programme. And there's a referral process where they'll be able to refer their patients in, and we'll be circulating details of that over the coming days. So there's a process there. We've used it before and we'll use it this time again.
Zara King, Virgin Media. Damien, can I just ask you about the turnaround times for tests there? I see you're quoting it as 3.1 days for detected and 1 day for not detected. Is that the first time we've seen it stretch out to 3 days? That seems like a long time to be waiting for a result.
Yeah, so I suppose part of what that's actually dropped already in the last sort of 48 hours as a result of the automation. That's the end-to-end. So just to recap on the process is you get a text to tell you that you're positive and obviously to restrict your movement with links to all of the public health advice. That's earlier in the process. So this is right to the end in terms of all the close contacts related to that person. So that had stretched out, and the automation that we've introduced this week has already brought that way back into the 2s and will probably even drop even further. So that was a sort of temporary blip, if you like, for want of a better word around it. But what we've seen is with the automation, it's brought that right back. The important thing, though, is when people get their text, which is in the middle of that process very early on when they get the result, they follow the public health advice, and that has all the necessary links for people so that they do that while they wait to get their call. But we've automated a lot of that process now. People can enter in their close contacts, they can book their test online. So we've really, through the work that the team have been doing for many, many months, have introduced a lot of that capability, which is really helping to accelerate and speed up the process as well.
And there was some communication from people during the week just about they were getting appointments for tests at places, say for 9:30, and then they were arriving at the centre and finding out the centre didn't actually open until 10, and there was a bit of a backlog. Have you seen much of that happening nationwide?
Well, certainly the centres are under pressure. I'm not aware of that particular examples are in terms of maybe that opening hour confusion. Obviously, apologies to anyone if that was to occur. Not aware of that issue. But in general, yeah, look, the testing centres are very busy. People are working hard. They're maintaining long hours, actually, in many cases, extending their hours to try and provide continued access for people as well. And in general terms at the moment, we're still managing to get people through in that sort of next day mode in the main. So that's working well. There are some pressure points, but we're trying to deal with those as well as best we can.
Professor Philip Nolan was saying yesterday that roughly speaking, for every 1,000 new cases, you get about 35 hospitalizations. Do you have any sort of statistic or figure as to how quickly that translation happens? So, for example, yesterday there were over 3,000 cases. I mean, at what point when someone is confirmed COVID, do they become hospitalised? Like, how will we start to know what that kind of number is? Yeah.
There's a couple of things about that conversion. It did convert through earlier surges, 30 to 50 hospitalizations for every 1,000 cases, and then 3 to 5 in intensive care requirements for every 1,000 cases. And we've seen that drop off a little because of the vaccination programme. But if you think, it's useful to think also of the spread of cases among different age groups, because we see different conversion rates in different age groups. So we have seen a tendency towards an increased number of cases in younger age groups in recent weeks, and they convert at a much lower rate. At the most extreme for those aged 4 to 11, for example, there's a very low conversion rate to hospitalisation and ICU, thankfully. For those cases over the age of 70, a much higher conversion rate. So much of it depends on the profile of cases with regards to age, in terms of how we can predict the impact over the coming weeks. And looking at that, so in answering your question, looking at that at the moment, where we see, as I showed, I don't know if you saw, you might have been here for earlier, in the profile of cases we have at the moment, there's a shift to the left in terms of preponderance among younger people, but the hospitalizations we see on the right-hand side among older people. So yes, time will tell in a certain way, but what we are primarily concerned with is people who are with vulnerable underlying conditions and those older age groups acquiring COVID, because they're the people who are more likely to convert into having serious illness requiring hospitalisation.
Okay, so how, like, what kind of numbers are you thinking though? Surely you're trying to project forward in terms of how many beds you actually need for these people. So do you have a number? Do you have a rough idea of what's
It's
looking?
always hard. All we can do is look at our experience looking back. Projecting forward is based on more recent experience. And what we've seen in this particular surge is a lower conversion rate to hospitalization. So I quoted for every 1,000 cases, 30 to 50 hospitalizations. We were seeing about half of that throughout this surge. And likewise for intensive care requirements, about half the conversion that we saw back in January. And that's because, as we've seen, and you know this, that the vaccine, at its most effective, prevents a serious end of illness. That is the kind of illness that requires people to go to hospital or need intensive care.
The numbers that we would have been, and still are, watching carefully are the projections from NEPHIS, which said that we could have up to 1,000 people in hospital. We could have up to 150 to 200 people in ICU. And as I said a couple of weeks ago, that's not out of this world in terms of happening, could very well still happen with rising case numbers. So that's what we're immediately focused on. If we reach 1,000 people in hospital, that will have major significant impacts. If we reach 200 people in ICU, it's 2/3 of our beds alone taken up in terms of ICU. So that's what we're monitoring very closely.
And I know you mentioned, Paul, those people that are outside the ICU with that high level respiratory intervention. I mean, are there some of those people that probably should be in the ICU, but you just don't have beds for them?
It's a good question. People at any one time in a hospital system, you go to a hospital, you'll find people getting these kind of treatments, non-invasive ventilation, high flow oxygen outside intensive care settings, because we can give that kind of care now in high-dependency units, in wards under supervision. What we're seeing now is more of those patients outside. You might have seen today's hour, the NOCA came out with their audit, looking back at our experience in this country of intensive care since February, March 2020. And they concluded that people who needed intensive care got intensive care. We were able to do that, but at a price. And the price was we had to redeploy lots of staff, and had to shift loads of staff from operations into to get training in intensive care. We increased the amount of intensive care beds available to us to 340, 350. That was care well outside ITU in temporary settings with staff that weren't normally there. But we were able to maintain that kind of quality of care, and we were able to provide care for those who needed it to date in this pandemic. The difference for us now is we are now for the first time providing intensive care to a lot of patients with COVID, 90 to 100 in any one day in recent weeks, but also providing all the whole range of healthcare otherwise, which includes serious trauma requiring intensive care, people with serious illness at hospital now for 2021. They wouldn't be the kind of wards they have in Hollis Street all the time. They've got some lovely new labour wards and elsewhere, but they've managed, even with the limitations of their infrastructure, to provide a safe space for women and for their nominated support partners, despite all the difficulties. And much of our experience in changing and loosening those restrictions that were there was the experience of such hospitals who showed that it could be done.
Yeah, you're right. That's not the question I asked, actually. So you're right about that. I mean, are you keeping an eye on a column? Are you making sure that they are easing the restrictions? Because we're still hearing from women. I get messages every day from them saying that their partners are still being kept outside of the process. So it is important to keep an eye on that.
Yes, we were reporting against it. We introduced a mechanism for people to contact hospitals and hospital groups directly if they've any experience such as those.
Site visits are taking place by some of our own senior teams on a regular basis.
Hi, Simon Carswell with the Irish Times. This might be a question for you, Colm. Do you have a percentage on the number of new cases that are amongst vaccinated people?
Well, we have breakthrough cases. I think I mentioned those in hospitals.
45% the positive cases are vaccinated. So it's hovering around that 45%. Is that fair, Damien? Yeah.
It rises all the time. It's rising because of the proportion of the population becomes. As more and more people become vaccinated, we expect to see more cases among vaccinated, and that's not a function of the vaccines failing. It's because more of the population are vaccinated.
Just on the booster program, it's limited obviously to particular age groups and cohorts at the moment. I know we don't have the problems that we had earlier in the year in terms of vaccine supply, but if a decision were to be made that we would go the Israel route and boost everyone over the age of 12, or how are we for supply if that scenario were to arise, Paul?
In terms of supply lines available at the moment, meeting what we have to meet, and should any further decisions be made about rolling it out, and Damien will describe, we ceased the supply lines just based on the process that we have through the EU, based on the main supply lines, but they can be triggered at any given time, so supply lines would not be a factor or an issue.
And at any one point, what would we have in terms of doses at hand?
Stock time, maybe?
Yeah. We've over 2 million in terms of stock. What we're managing, I suppose, the balance that Paul referred to is we've ceased some of the deliveries now through to allow government, I suppose, there's policy decisions in terms of redistribution of vaccines. We've already, as you know, we moved some vaccines to Uganda through a bilateral agreement, and government have made commitments to the international COVAX system in relation to countries that are probably not as well off as ourselves. So we're happy we have enough stock in terms of what you call the at-risk groups initially identified by NIAC. I think it's about 1.8 million would fall into that bucket. And as you say, Simon, if it was to be done for everyone, we can reactivate the deliveries then, which we'd be confident would fit in with a timescale around it. So we're trying to balance that in terms of the ethical piece of it in relation to making sure we don't hold a load of stock that could be used elsewhere and keeping enough stock to support our booster programme. And at the moment, we're happy we have that good balance in place.
The message from NEFIT yesterday was ration our discretionary activities back to kind of a budget of social contacts again. Clearly their social activity has gone up, and NEFIT is saying that that's the reason for the increase in the cases. We used to track the average contacts, and Damien, you might have this. I'm just wondering where it's at now, and have you noticed through the testing and to the tracing operation a big spike in social contacts from August through to now?
So the close contacts numbers are still, I suppose, to be honest, I think in terms of numbers, it's just over 3. But in reality, we know in terms of people's mixing in society, there's much larger numbers of that going on. So it probably had more relevance when we were in more constrained times than it does in a current context.
And is that something that we're going to have to watch now, or are you going to have to track more closely? Because clearly people don't have an average of 3 contacts at the moment.
Well, I suppose there's a limit to how much any system, contact tracing system, can track in that sense. There's an element for ourselves, I suppose, in terms of our responsibilities, and others may want to talk to that.
Sorry, apologies. There has been, throughout many phases, a reluctance of some people to give their full list of contacts. So I might have 10, I'll give 3 or 4. So we've always been, and our call scripts are always encouraging people. It's really important you give us all of your contacts. I think recent indications would be it's gone up to about 5, but there is a factor for us to make sure people feel comfortable and give all of their close contacts.
Just one question from me. I was contacted by someone who had an adverse reaction to a vaccine after the first dose and left them in a very difficult situation. They're very much in favour of the vaccine programme, but the adverse reaction they had has left them, and they've been receiving conflicting medical advice as to whether they should get a second dose. While the adverse reactions are small as a percentage of the overall doses that have been given, does the HSE need to provide more support to those people, both in terms of clinical advice or advice as to where to go from now as to seeing out their course of vaccination?
There are a range of side effects, from common side effects to more severe, and at the very end of the severe range are anaphylactic reactions, severe allergic reactions, which are thankfully very rare. There are very few contraindications to the second dose, but anaphylaxis may be one of them. So certainly anybody who needs advice, we're happy through our own vaccination teams, and any of the vaccination centres are well equipped. The leads and clinical leads in these centres are well equipped to give advice to anybody.
Anybody else? Question? Yes, everybody.
Rowan Smith from the Irish Daily Mail again. Just a quick question. Do we have an update on how many people are unvaccinated? I think the number was 370,000 a while ago, a couple of weeks ago.
I wouldn't have that number here, but we can feed it on to you. It's obviously reduced by the numbers we're sort of talking about it, about, that 1,500 a day. It's coming back on a very slow basis, but it's not going to be, I suppose our emphasis, the important point at the moment is to get to those groups that are most at risk that we talked about earlier in terms of the uptake initiatives, while obviously trying to bridge the gap between that highest uptake in Europe, the 93% to 100. So we can feed back the exact figure, but it's not going to be dramatically different to where we were. But that pace obviously is still continuing. If we can keep that 1,500 a day for as long as possible, clearly that's in all of our interest. But as I say, our priority really is to get to the groups that are most at risk that we mentioned earlier in terms of, as Colin said, the medically vulnerable, some of the ethnic communities and people who are most exposed to the virus, most at risk from it.
3,000 primary vaccinations being completed over the last week or so, and that's dose 1s and dose 2s. So they're all coming into the mix, thankfully.
Just the other question, you saw during the week that the NHS are implementing mandatory COVID vaccines for their health staff. I'm just wondering if there's any consideration or further consideration being made to that here.
Ultimately, policy decision, but from our perspective, we've had a really strong take-up. I want to acknowledge it across the system, across the board. We're still encouraging and communicating a smaller number relative of staff, and in some cases, staff would have to be redeployed from non-frontline care. And that's a local decision on a risk-based assessment. So no policy decision change right now here in Ireland.
The European Medicines Agency has been saying just in the last few hours that they should make a decision next month on the Pfizer vaccine for 5 to 11-year-olds. Obviously, NIAC would have to approve that, but are you planning for potentially rolling vaccines out to that age group, possibly before the end of the year? Are you kind of setting aside, some doses, or do you have a kind of doses on the way in case that the green light is given for 5 to 11-year-olds?
One of the reasons we sustained our infrastructure, which we have done in place, and many other countries haven't, so our vaccination centres, obviously GPs, pharmacies and others, was to facilitate and meet any decisions, whether it's in terms of boosters or acceleration into younger age groups. So again, we would work very closely with NIAC, looking at any kind of pipeline of decisions and operational planning that we would have to do. So, we would have the infrastructure, we would scale up should those decisions be made.
Is that something you'd like to see? Do you think that, based on the evidence you've seen so far, that it would be beneficial?
We leave the decisions on that. NIAC are the medical experts. We are not. In terms, they research the evidence, they make the advice, they give it to government. Government decides. So we execute then after that. So we were certainly anxious to see the healthcare workers booster program, but all evidence is assessed by NIAC, and they're the experts.
US, where the FDA have permitted use of vaccine in this age group, and what would be of interest would be the uptake, because as we've said many times, thankfully serious illness and hospitalization and admission to ICU is very uncommon among children. For the large part, children have either no symptoms or mild symptoms from COVID-19. So it would be interesting to see, we'd have learned, the EMA will have learned, and NIAC will have learned from the experience in the United States, where it's been rolled out now, and the levels of uptake for parents who will choose to consent or not consent for their children.
And then just last one, Paul, you were obviously kind of talking about people should cut down on their contacts over the next while. I suppose there'll be a lot of companies at the moment wondering if things like, an office Christmas party should go ahead, and whether, you think that would be something that's appropriate. What would your advice be to companies thinking about something like that?
Well, I think the cutting down on contacts emerged from the NEFIT advice yesterday and fully support it. What I was saying there as well was just everybody should make individual risk assessments. The policy is there. People can meet in restaurants and should, and people will meet in restaurants. But just take individual risk assessments. What am I going to? What do I plan to go to? What might I cancel and go there instead? So I think they are all individual assessments we'll all have to make. It is facilitated now. Society's open now. Restaurants are open. And many restaurants all across the country putting in good processes and good procedures. So I'd make two calls. One, to individuals, just assess the risks that you're taking on in the coming weeks. And secondly, to enterprise and business and retail and restaurants and others, make sure you have the protections in place that protect your staff and protect the public.
Hi, I'm Michelle from the Journal again. Just one last question. The last almost 2 years have obviously been very difficult for healthcare workers, those working in the healthcare system, and they're now facing into another COVID winter. Are there any kind of additional supports that you're planning over the next couple of months or through the winter to support healthcare workers who are suffering from burnout or other sort of mental health impacts of the job?
I'll let Anne comment here as well, but firstly, we acknowledge, I think each of us today have acknowledged the massive pressures that our teams have worked through 4 waves, another wave, and a cyber attack, and they've been phenomenal throughout it all. We've been putting in a range of supports through all across the services, employee assistance program supports, mental health supports, physical wellbeing supports, mental wellbeing supports, and that's part of our ongoing support throughout the system. And it is throughout winter as well. Really conscious of the pressure levels, anxiety levels that's on our teams, and I want to acknowledge what they've done but we will provide all the reasonable levels of supports that we can for staff.
Yeah, no, I mean, I think you may recall earlier in the pandemic, we developed our psychosocial framework, and part of that was about staff. And as Paul said, we have an enhanced employee assistance programme. But there is no doubt but that this is very difficult, and winter will be very difficult, and our staff are under huge pressure. And unfortunately, when it comes to clinical frontline staff, you know, there aren't a lot of options for us in terms of needing those staff at work. So our priority is to try and ensure that we can support them. You know, we have a range of initiatives there, but it will be difficult.
Is everyone okay? Niamh? Okay.
Cyber attack, maybe Anne, you could answer this. Where are we now in terms of the backlog in the laboratories and starting to catch up on cancelled appointments?
Yes, so in terms of catching up, so they're all part of our, I suppose, our waiting list initiatives really, and we have seen a big jump in terms of the outpatient list in particular. They were hugely impacted in some sites. A lot of the more critical, if you like, the time-dependent work has continued. But certainly the cyber attack, there is a backlog that is still there. There's no doubt about it. It has contributed to our waiting lists, and they are part of those big numbers that I put up earlier. So again, a slight turn down now in our scopes. Inpatient day case not growing, outpatients still a big list. And that is a mix of COVID and cyber attack cancellations.
Thank you.
Zara King, Virgin Media again. Sorry, people are just asking for the source of the research into the number of pregnant women vaccinated, the 58% that are vaccinated and 75% of partners. People are just wondering where was that research done and what's the source of that research?
It was a point-in-time exercise across all 19 maternity units during one recent week. So they were all asked to look at all inpatients over 1 week, and it was self-reported. In other words, the women themselves reported their vaccination status and that of their nominated partners. So all 19 units participated.
I know you were talking about this earlier in the week. Just what was the statistics around pregnant women in ICU with COVID? I know you had been talking about that earlier this week. Where are we at with that?
Yes, if you look at NOCA released a report earlier today, Zara, and there's a section on that on their experience. I think the total number, maybe it's in their report, was 58 over the duration of the pandemic, but over 50% of those were since summer of this year. So what we saw was relatively a small but concerning number, but an increase in cases over the summer months at one stage approaching between 8 and 10% of those patients in ICU, and a much higher proportion when you consider of the potentially pregnant population. There were a high proportion. So we did see an increased number of cases. A big concern to those providing care for them in intensive care because of the complexity of care and clearly the complexity of providing care to someone who's pregnant and protecting their pregnancy too. So that the first question you had was a recent survey across all 19 units for inpatients, asking them to report their vaccination status and that of their partners. And the second is captured in the NOCA report, which came out earlier today, which reports the experience throughout the whole pandemic in terms of admissions of women who are pregnant or post-pregnancy to intensive care units and the timing of that in relation to the surges.
Sorry, can I just ask, when do you reckon you'll have all the healthcare workers boosted? Like, what's the deadline for that? Or obviously not a deadline, but, you know, like, I suppose, how long will it take, do you reckon, to do it?
Yeah, I suppose just the bulk, Zara, we'd hope to hit maybe over the next 6 weeks, but just bear in mind with the 6 months, then some of the people, if healthcare workers have joined, like there's thousands of people turnover every month in the health system, public and private, so it will continue almost into next year in relation to people hitting the eligibility then to get their booster shot. So, you know, it will run for a period. But in terms of if you like, the major campaign we did last year, we'd expect it to run over about a 6 week period, given the 6 month profile that we've looked at. So we've looked at the profile of people when they're due to come. So we'd hope to hit the majority in that period, but it'll be ongoing then based on people becoming eligible for the booster shot. But it will shrink down then fairly quickly then over time, you know.
Is everybody happy? Okay, well, thank you very much.